What I'm going to talk to you about today is I really want you to get 4 or 5 good pearls, each of you, to be able to take to your own practice. If I haven't achieved that today, then I've failed you, and I don't think I'll fail you. So what I want to do is basically give you an approach to the types of structural thinking that you need to think about when you are providing pre-travel care to your patients, and usually that's in the last minute of a consult, right? By the way, doc, I'm going to India. Or, by the way, doc, what do you think about this trip that I'm taking to Peru? And then you just shove them off to me or someone like me. But I think if we think about travel medicine as an extension of what we do, I'm not really proprietary about the work that I do. In fact, I work closely with pharmacists. I work closely with nurses, nurse practitioners. I work closely with primary care physicians. I think that we all are ideally positioned to provide our patients with care that will keep them healthy. I think the biggest barrier to travel medicine for our patients is that there's a cost behind that. And that medical services plan really, unless you're giving them a tetanus shot or an MMR vaccine, there really isn't any medical services plan component to that interaction. And so quite often as family physicians, we try to, we're not the type, most of us aren't really designed to ask that patient that we've had a relationship with for 15 years, oh, by the way, I have to charge you for that. What we try to do is we try to fit it into a blood pressure check or that sort of thing. And so what I would like to do for you today is give you the key elements that will make you feel comfortable of when you can raise the hand and send them over to someone who will spend perhaps more time with them, or perhaps I'll empower you today and give you some extra tools that you'll be able to use in your own practice setting. Now, I do want to say a couple of things about the way I give talks. Questions can be asked at any time. If you ask more than 3 questions, then I'll start to bug you. But in a nice way. But the point is I wouldn't mind if we have a good interaction. What time do I have until? 2:45. 2:45, so we have 1 hour and 8 minutes. So in that hour and 8 minutes, I think it's important that if you have a burning question, raise your hand, ask it. And we have a microphone, we'll bring it over to you, you can ask. And I want every one of you to get something out of this talk. So, what we're going to talk about are 5 different key points. We're going to understand and apply the 3 R's of vaccination. We're going to talk about the VFR concept, which I'll explain shortly. The high expectation traveler. I'm always jealous when I do surgical assists with orthopedic surgeons because many of those orthopedic surgeons come up, or their colleagues come up with really cool inventions. If there's one area of medicine that I'm green with jealousy is about how many inventions that orthopods actually can come up with. Well, I came up with one, and it's used internationally now. It's called the high expectation traveler. So I'm going to tell you about what that means. Also, develop an approach to the prevention of insect-borne illness, and develop an approach to the prevention and treatment of travelers' diarrhea. And if we can do that in the hour and 7 minutes that we have left, I think I'll have served you well. I'm going to use case studies to illustrate my points. And I'm going to spend more time with the first 2 case studies than I will the last 3. But what I'm going to do is tell you what the differences are in the other 3 versus the first 2. So we're going to talk about a family to India, South America, then Dominican Republic, China, and Southeast Asia. So the first case is a family with 2 little boys. These are all real cases, by the way. A family wedding to India with a side trip to Southeast Asia. And this family of 4 to India is a father who was born and raised in Canada. He's Indo-Canadian heritage-wise. He's 38 years old. The mother is a couple years younger. She moved in 1998 to Canada after they got married in India. And they have 2 boys. One's 12 and one's 10, both born and raised in Canada. So the first key concept to understand is, what is a VFR? A VFR is what we call visiting friends and relatives. And many of you have heard this term before, and it's a term that you need to think about when you are, one of the first things you need to think about in your triage when it comes to travel health, pre-travel health, is, are they or are they not a VFR? They are an immigrant, ethnically and racially distinct from the majority of the population here in Canada, where they're living now, which is considered the higher income country, who returns to his or her own home country, the lower income country, to visit friends or relatives. Now you may wonder, does that include the father who was born and raised in Canada? Does that include the 2 children? And it is. By definition, CDC does include this as the definition. Family members such as the spouse or child who were born in the country of residence where they are now. And that is because there are cultural factors that influence the decision-making with regards to that child's health, the husband's health, for example. It's not just the mother in this situation of the family of 4 is not the only VFR. The VFRs are the entire family group. 1 out of 3 Canadian travelers, and I'll exclude the United States, so someone who's leaving Canada and not staying in the US as part of their journey, 1 out of 3 Canadians is actually categorized as a VFR. They have a higher incidence of pretty well everything. Traveler's diarrhea, malaria. In fact, 95% of all typhoid fever in Canada is imported by VFRs. Tuberculosis, Hepatitis A, and STIs. Now, this is I broke the rule, yes, but I'll read it to you because this is an important slide, because VFRs can be your toughest travel patients. They lack an awareness of risk. If you think about it, quite often you'll see a family such as this coming in only wanting shots for their children, and they don't think that they need anything. And that's farthest from the truth. Typhoid, for example, you lose your immunity from typhoid after a few years coming into your host country or to your new country. And so they lack an awareness of risk. They think their children or the people that are from North America are at that risk that are highest. The next is from CDC. Less than 30% have a pre-travel health encounter. In Canada, it's less than 10%. Financial barriers to pre-travel health. Many of these are immigrants who have saved a lot of money to go back to visit a family member, or who are going back because on short notice because a loved one is ill or has just died, or, for example, a wedding in this circumstance. Clinics are not geographically convenient for many of these VFRs, and there are cultural and language barriers. One of the key things is lack of trust in the medical system. They come from an area perhaps where the medical system is much different than ours, and they're still getting acclimatized to the style of medicine that we practice. And like I said earlier, last-minute travel plans and longer trips. These people tend to come to us the day before they leave, expecting us to help them, and also they tend to have longer trips. Did you have your hand up, sir? No. They also travel to higher risk destinations, such as, and also they stay in homes and live in the local lifestyle. That often includes a lack of food and water precautions and the use of bed nets, which they don't often use. And like I alluded to earlier, they believe that they're immune. VFR health beliefs likely contribute to lower rates of vaccination against Hep A and typhoid and infrequent use of malaria chemoprophylaxis compared to other international travelers. So a little bit of fear will actually get them to behave in the ways that perhaps we'd like them to. This is their trip. So once you kind of get a feeling for who they are in your practice, then you want to get your itinerary. In my practice, my receptionist is trained in such a way that trying not to tick people off, because people want to know. The most common question that people get or my receptionist gets when people phone her, is what shots do I need? And how much will it cost? And they don't understand that she's unable to give that information to them. Even if we've had 5 of almost the exact same itineraries in a row, to India that day, because India, and I'll explain this to you in the 3 R's of vaccine, but you can have 5 different itineraries for India with completely different medical advice. So what you want to do is you want to get a feeling for what they're up to, what type of traveler they are, what's their style of travel. So they are flying to Delhi. Then they're going to be in the Punjab for 3 weeks for the wedding. They're going to do a little bit of shopping in Mumbai, and then they're going to go to Goa, and Goa is in the basically the mid to southwest coast, very tropical area. And then, because they're already there, they're going to do a gap adventure. Now it's called G Adventures. They're doing a tour for 3 weeks in the rest of Southeast Asia. Does anyone know what Shoreland is or what Travax is? It's not cheap. It's about $1,000 a year to subscribe. But what it does for me is gives me I use them primarily for these malaria maps. And you get to know geography quite well when you do this a while. And what these malaria maps do, and by all means, like I said earlier, I'm not proprietary about my knowledge. I'm very free to help my colleagues at any time. You just have to go to yellowfever.ca, which is my website, and get my phone number from there and just call me if you ever had a question about something, if you felt that you just needed 1 or 2 little things to help move you along. But what Travex does, what Shoreland does, it's an American company. They have a board of directors that are physicians that basically survey the world through a variety of different networks, providing me and my practice and many other practices throughout the world with a really cool set of tools. And one of those tools are these malaria maps. And you'll see here that they're in Delhi, and then they're in the Punjab there. And red means that you need malaria medicine. The hash-marked pink areas, you may or may not need it depending on the style of traveler, which is defined up here. And then these areas that are not in any particular color, either white where Delhi is, or these little check marks here that are in white and black, you don't need anti-malarial medicine. So really, when they go to Delhi, and when they're in Punjab, they don't need malaria medicine. And that's most travelers do not need anti-malarial medicine for the Punjab. And then all of a sudden we had 2 quick hands raising. Yes?
How do these maps compare to the ones through CDC travel?
Okay. If you have time afterwards, we can go on the computer and we can go online. Do the computers have access to the internet here? If they do, I'll show you. They're not as good. If they were equitable in terms of the information, then I wouldn't spend $1,000 a year for them. I can tell you for a fact that the whole point of why I do that for my patients is it's quite easy to give someone a pill. It's quite easy to say, oh, you're going to India, you might need to take this medicine. But they're making a voluntary decision most of the time to travel. And why should we be giving them iatrogenic reasons to have a lousy trip? And so I think it's more important that we narrow down whether or not these people need medicine in the first place. So if you use the CDC, for example, and Health Canada basically give you a regional description, and unless you know your geography really well, you can use those. They're quite good. But I see a lot of people who don't want to go on medicine. And if I can show them a picture, and I could show them, well, you don't need it for this, but you need it for that, they buy into that. But if they say, oh no, my friends didn't need to take medicine, and their doctor or their pharmacist said, or their travel agent quite often, said that they don't need antimalarials, or their pastor or whoever that they're seeing, they don't need to take medicine. I think it's a very powerful tool of convincing people one way or the other if they need medicine or not. And I don't want to give people medicine they don't need, but I'll be first in line to give them something that they actually do need. And so I think if you're in a bind, that's a good tool. But I think For someone like myself who does this, you know, I see 30, 40 people a day. That's what I use. Yes?
So for malaria prevention, wouldn't the time of the year and the weather be that time?
Well, if I heard you correctly, the first question just for the recording was whether or not other options for malaria advice over the internet, such as CDC, was appropriate, and yes, it is. The other question is whether or not certain times of the year may influence your decision as to providing malaria medicine for people. Is that correct? Yeah. By and large, that is true for many regions. This map is the same map 12 months of the year. There are certain countries of the world where it is seasonal, but usually what I'll find, and this is quite interesting, if you look at Geosentinel data for South Africa, we see that malaria risk exists 12 months of the year in Kruger National Park. It's the only part, and that area is the only part of South Africa that has malaria. But because we have a lot of South African physicians, and there are probably South African physicians in this room, I have found that my experience that there are certain trains of thought that in the dry season, you don't need to take malaria medicine when you go into Kruger. Our data shows otherwise, that there is malaria risk in that region throughout the entire year. So you might even find things that relate to seasonality. Seasonality in malaria risk isn't as big an issue as you'd think. And I think that there is probably more seasonality with regards to dengue fever, where there and other types of insect-borne illness. But malaria, yes, there are peaks and troughs. But I just don't think that we use seasonality to as large a degree as we probably need to. Yeah. I hope that answers your question.
Well, wintertime in Delhi, but that's still be an issue.
Delhi is not, okay, I'm going to actually go back 10 years, and I'm going to tell you what this map looked like 10 years ago. This map was all red 10 years ago because our data wasn't good. And because our data wasn't that good, we weren't able to geographically pick out and tease out the things that we know now. We know that the risk, 10 years ago, most people going back to India and the Punjab were getting malaria medicine. I can tell you that you don't need to do that if they're just going to Delhi, getting picked up by their family, going straight to the Punjab. Delhi is not considered a malaria risk area, okay? And that might be news to you. If that's one pearl that you get out of this talk, that's the first one. And, but Mumbai is a risk. Even if you're there for one night, you should be taking anti-malarial medicine. Even people on cruise ships, and this is an interesting thing. You'll see a lot more oceanic cruises and a lot more cruise ships that are doing this 30, 40, 50-day cruise. And they start somewhere over in Southeast Asia or Hong Kong, and then they work their way through and end up in Africa, and then they'll do a safari, and then from there, quite often, they'll keep on going from Zanzibar, and they'll go up through the Suez Canal, and then go even all the way up high to the Baltics. Like, these people are cruiseaholics, but there are a lot of people who do this, and almost invariably, if they do this cruise, there will be a one night where the cruise ship stays in port in Mumbai. And quite often they'll stay another extra night in Goa. And if that's the case, well, then they're at malaria risk. And then you need to consider whether or not they are wanting, you should be offering them anti-malarial medicines for those. It just takes one bite from a malaria mosquito. But it has to do with relative risk. And yes, the longer you are in a risk area, well, for sure. But the rule of thumb here is Mumbai and Goa are in the high-risk areas. Let's take a look at the rest of their trip. This is that G Adventures tour. They start in Bangkok, and then they fly to Siem Reap, where the temples are at Angkor Wat, and they go down to Phnom Penh. They go to Snookville, which is in the southern coast, and then they fly into Vietnam. Actually, they don't fly, they'll take a bus or something, and if I recall from this particular trip. And then they go along the coast to Hanoi, and then they'll fly to Vientiane and Laos, and then go to a few of the other more common heritage places that you'll visit in Laos, like Luang Prabang. And then from there, they'll end up in Chiang Mai, fly back to, actually go back by land to Bangkok, and then home. So let me show you the malaria maps for this. I look at Thailand as the mushroom, it's kind of like, looks like a mushroom cap. And this is kind of like the cheese on the mushroom cap with a little bit of extra ooze, right? And the point is here's Burma, here's Laos, and here's Cambodia. The highest risk for malaria, and pretty well the only real risk that you need to think about, is this little edge. And it's for really people that are backpacking in this region. People who are going to Bangkok, Chiang Mai, Chiang Rai, and Phuket, and down to the Koh Samui and Pattaya. Those areas you don't need anti-malarial medicine. So 9 out of 10 travelers to Thailand do not need anti-malarial medicine. The key question is are you going to be backpacking? And are you going to be trekking? Are you going to do jungle treks in Thailand? And if you're going to do jungle treks in Thailand outside of Chiang Mai or Chiang Rai, or if you're going to go by land into Laos, that is a malaria risk. This is a really cool map. And this is for Cambodia, and you'll see it's kind of segmented, and it almost looks like some type of vegetative thing. But it is related to vegetation. Does anyone know why this region here of Cambodia is basically risk-free, including Phnom Penh and Siem Reap? Does anyone know why that area is considered a low to no malaria risk zone? Close. It's a deforested valley. And because it's deforested, the habitat, the natural habitat for the Anopheles mosquito is minimized. And so it's affected habitat. And the other really cool thing about this area is that it gets flooded once a year. If you follow the Mekong River, it basically goes through Phnom Penh and then out into Vietnam, out into the ocean. But because it narrows right around Phnom Penh, the Tonle Sap area of this area is quite cool. It's the only river, this Tonle Sap, this river right here, which flows from here to here into the Mekong, it reverses. Actually, there's so much flow from the monsoons that the water goes backwards, and then as it flows back, this whole lake then fills up and then it actually floods. And you'll see, if you ever do a Google search on it, Google Images on Tonle Sap, T-O-N-L-E-S-A-P, and do housing, everything is on 10-foot stilts. It is because of that. And so this area here really doesn't have malaria. It's in the more jungle areas. And I can tell you that malaria, except for certain countries, is more of a rural problem, and dengue fever is more of an urban problem. So all these people are going to have risk during the day as well, in, for example, Delhi with regards to dengue fever. But so what they're doing is the only risks that they're going to have on this trip is the Cambodia part, or the southern coast, where they're spending a few days in Sihanoukville. And then from there, they go to Vietnam. And what's really interesting about this is that most of the landmass of Vietnam has malaria. So you think, oh, I should be giving them anti-malarial medicines. But 95% of all travelers to Vietnam will not enter a malaria risk zone. They'll actually go along the coast. And almost all travel to Vietnam is along the coast. And most backpackers will not venture here, other than in this area up here. And you have to find out if they may or may not need anti-malarials there. But I can tell you, most Thailand travelers don't need malaria medicine. Most Cambodia travelers don't need malaria medicine because they fly into Phnom Penh, they go to Siem Reap, do their Angkor Wat kind of experience, go back to Phnom Penh, and then they go along there down the Mekong into Thailand or into Vietnam, and they don't need anti-malarial medicine. So once again, for this particular leg of the trip, they won't need it. Laos is a different story. Laos is all red, except for one little place. And it's the biggest place in the country. It's the capital, Vientiane. And it so happens that that's the only part of the country that doesn't have malaria. Every other square inch of the country has malaria, including the 3 different places they'll be visiting. So a lot of people, in Chiang Mai is over here in Chiang Rai, so people will, you have to ask them, are you flying to Vientiane or are you doing land travel? And quite often, if it's land travel, they may be going through the nighttime, so they may be traversing through malaria risk. So, yes?
For people that are going to Chiang Mai or Chiang Rai and doing hilltop tribes trips that are more popular, they're trekking,
That includes overnight stays?
overnight, usually 3 or 4 days local out of Chiang Mai and Chiang Rai. That's the big thing in northern Thailand right now.
Yes. This is what I would say. You have to then ask them another question, because you will get one of 2 answers. The first question is, or the question that you'll ask them is, are you going to be spending evenings outside of Chiang Mai? Because many of these so-called treks or journeys are day trips, and they always go back into Chiang Mai by nightfall where they have their dinner, and then they do another thing like go for the elephant rides or do whatever. So they might, their tour operator might, depends on how they label it. If they're doing a 3-night jungle trek where they're going backpacking into the jungle, that's where you need the malaria medicine, okay? With regards to this family, what is the minimum age for doxycycline to be used for an anti-malarial? What is the age? It's younger than that even. It's 8. What are the ages of these boys? 10 and 12. So we have a choice for them. We can offer them Malarone, we can offer them doxycycline. They are in a chloroquine-resistant area, including India. You will find many Indo-Canadians asking for chloroquine still, and I get that weekly. And I educate them. I said, chloroquine works great, except for the malaria that's probably going to kill you. And so I think we need to rethink about the type of anti-malarial you need to take. But remember, they're thinking that they need chloroquine for the Punjab. And so you can give them a bit of a pat on the back and say, you know what? We got news for you. We don't need to give you chloroquine for your trip anymore. If you're just going to be in Delhi and then you're going to get whisked over to the Punjab, you won't need your anti-malarial medicine anymore, or at least for now. Things change. And mefloquine. Why would we not use mefloquine for this family? Is there something regional about mefloquine that we don't use mefloquine in this part of the world? We are seeing significant mefloquine resistance in Southeast Asia. That's been going on for 15 years now. And that is something that seems to be spreading, fortunately slowly. Let me ask you this. Is there really, because of availability of Malarone, and I have no conflicts. My talk today is not sponsored by anybody or anything. This is a completely non-pharma talk. When do we use mefloquine? When should you use mefloquine? Longer trips, why? So Malarone's really expensive, and mefloquine you take once a week. It requires only 1 missed dose of doxycycline or Malarone to get malaria. But because the half-life of mefloquine is so long, you could, if you wanted to take, like I often will try to tell people to take their malaria medicine on Mondays, because I call it Malaria Mondays. And so then they remember. And because when you're traveling, you're not on your, your iPhone or your calendar or your iCal or whatever. You tend to lose track of time. And so I just tell them Malaria Mondays. Try to do it that way. You're quite right. I think the few travelers that we see that warrant mefloquine are those that are going on long-term trips that usually are in one place. They're sessile. They're not going really anywhere else. They're going to be a long-term missionary, is an ideal person for taking mefloquine, Central Africa, for example. The problem about doxycycline, mefloquine's about $5 a week. Doxycycline's about $5 a week. And Malaron's $5, sometimes it depends on which pharmacy you go to, $6 a day. But it's cost effective if you're on a short trip, because you only need to take Malaron a day before, once a day while you're in the risk zone, and then for 7 days afterwards. Malaron may not be a good choice for this family because they're going in and out of 3 different zones. The first zone they enter is Mumbai and Goa, and then the second zone after a few days, they're in southern Cambodia, and then once again, after a few days, they're in Laos. I think doxycycline for this family would probably be a better choice. And what I would do are several things. I'd ask them when they're leaving, of course, because doxycycline is very similar to Malaron in that you take it a day before, 100 milligrams a day before, once a day while you're in the risk area, and then for 7 days or 30 days afterwards. It's much longer. It's for 4 weeks afterwards. So the common side effects of doxy, as we all know, are sun sensitivity, GI upset, and you never have them take it before bedtime. Never take doxy before bedtime, because if you have any reflux, you will have significant esophageal discomfort. And you always take with lots of water doxy, because if you don't tell them that, or the pharmacist doesn't tell them that, and they take it with just a little bit of water, and that doxycycline lodges and sticks to the esophagus, you can burn a hole right through the esophagus. So you take doxy with a lot of water. One place that I wouldn't use doxycycline for is East Africa. We're seeing a lot of resistance to doxycycline treatment or prevention failures in East Africa. This is relatively new data, and I think that doxycycline has a very good role if you're going in and out of risk areas for a period of time, and that's what this group is doing. And they're certainly not a candidate for chloroquine. And I'll tell you why you shouldn't. And these are the types of people you shouldn't give mefloquine to. Never give mefloquine to a colleague. Never give mefloquine to a pilot. Never give mefloquine to a person who carries a gun, like a police officer or a Brinks security guy. Never give mefloquine to a nurse. Never give mefloquine to someone whose judgment will affect someone else. Never give mefloquine to yourself. Unless you've tolerated it before, but there have been studies that have shown that even if you tolerated mefloquine 5 years before, you still can get the neuropsychiatric side effects. You don't instantly get psychosis with mefloquine, and you don't instantly get a seizure with mefloquine. Maybe, well, obviously you go from nothing to seizure, but there is a prodrome that most people don't know about. And you become irritable, then anxious, then depressed, then paranoid, then psychotic. And it's kind of like a triangle. There's more people who would have that one, then that one, then that one, then that one. And people jump that triangle quite quickly if they have a strong family history of neuropsychiatric illness, or if they themselves have anxiety or depression and is relative contraindication to probably an absolute contraindication. If someone is going on a long-term trip and you want to give them mefloquine, but they have a history or a strong family history, what you might want to do in either situation is I urge people to see me well in advance before a trip, because I use that time to their advantage. What I want to do is I want to basically give that person an opportunity to try something. Yeast vaginitis in some women can be quite terrible. We're giving them all these other fancy schmancy things to go traveling, and the last thing we forget to tell them is, yes, your doxycycline can cause yeast vaginitis, and that's the worst experience that they had on their whole trip, was an iatrogenically induced problem. So the thing that I would like to say is that if you have time, give them a week's worth of doxy. Tell them to take it during the day sometime, at the same time each day with lots of water. And the pharmacist will tell you the restrictions in food and calcium and milk and all that other stuff. And see if they tolerate it. Better yet, tell them if it's in the summertime, tell them that, if 15% of people get sun sensitivity in doxycycline. Go outside, go golfing, do whatever you can to see if you'll elicit these side effects that you don't want to experience when you're actually traveling. You need protection against both UVA and UVB to minimize your chances of a sun-induced doxycycline reaction. So most sunblocks now have that, and I would recommend to people that they do have a trial of doxy before they leave Canada. You can always go from chloroquine or mefloquine quickly over to doxy and malarone, because malarone and doxy have a very short half-life. So you can get into their therapeutic index quite quickly. Whereas because these other chloroquine and mefloquine have half-lives of a week, it takes several loading doses, kind of like digoxin in a way. But it takes several loading doses to get them ready. I'm going to tell you something, it's most anecdotal because I don't think you're going to have this experience. But if you knew that this person always took mefloquine and never had a problem, and they didn't have a job where they where people were dependent on them, then it would be fine if you wanted to digitalize them in a way. You can give them mefloquine daily for 3 days in a row, and that basically gets them to a 85-90% therapeutic window quite quickly. And so you can actually give mefloquine once a day for 3 days in a row, which is equivalent to basically giving someone mefloquine once a week for 3 weeks. The reason you don't give mefloquine to someone who's in a position of responsibility is because they may do fine on the medicine, but if they have an adverse outcome, let's say, for example, you do obstetrics, and you went on this trip and you took mefloquine because you were doing some Habitat for Humanity thing in Central Africa, and you took mefloquine because everyone else was taking it and it was once a week, and then what happens is there's an adverse outcome in one of your patient's obstetrical cases 2 weeks into your trip post-travel, or 2 weeks post-travel. When CMPA talks to you, and when their lawyers look at you, they're going to say, well, you're on mefloquine. Why are you taking mefloquine? That impairs your judgment. And so I think, just to be on a safe side, malarone's a much cleaner drug, and I think most of us aren't going on longer trips. There have been some cases where that's happened, and mefloquine can impair judgment. Yes?
Sorry, I'm not clear. Is this an idiosyncratic reaction with the mefloquine? Or dose-dependent, or?
What is it? Judgment?
Yeah, the impairment in judgment,
okay.
The psychoses.
It's not necessarily dose-dependent. It can, as long as you're within the therapeutic window, you start to develop nightmares. And this is a very small percentage of people. 5 or 10% of people will get neuropsychiatric irritation, where they get irritable. They might feel a little anxious. They'll have more, they have vivid dreams that are dysphoric.
Like, I mean, kids with ADD that are going to these areas, and maybe, or people who have depression, you would just not offer them that drug then?
I probably give mefloquine once a month, and I see about, I don't know, 700, 800 people a month. Yeah. It's just a medicine that we just don't use. It has a very defined purpose. When something better comes along, we use it. And I just think that mefloquine is a medicine that has a very good role. I just think its role is very, very narrow. Yeah. Having said that, if you're pregnant and traveling, you can't take Malarone, you can't take Doxy. So if you're going to a chloroquine-resistant area, then the only choice is mefloquine. We have little data, but the data is actually pretty good. So in a pregnant woman, that would be an excellent choice. And you want to make sure that if they're going to be in a chloroquine-sensitive area, that you offer them chloroquine, of course. Let's say, for example, they can't help but go, and they're going on a trip to Haiti or the Dominican or to somewhere in Central America. Those are the hotbeds for chloroquine sensitivity. Okay? I hope that answered your question. So like I said, this family has 3 segments of the trip. We're 7 nights, 1 night, and then 5 days. And so there are 3 segments of malaria risk. I think Malarone might be a bit expensive for them, so I would offer them a trial of Doxy. And the dose is the same regardless of what age. Malarone is different. We have Malarone pediatric tablets, and it's based on, and you can just look it up in the CPS or look it up on your iPhone. Every time I see a traveler that's going into a malaria risk area, even if I don't give them anti-malarial medicine, let's say, for example, they're traversing through a malaria risk area, but they're only doing it during the day, I always put this in my notes. And this is maybe the second pearl that you can get out of this talk, is to simply write that in your chart as part of your chart notes. That's F equals MUPO. That's fever equals malaria until proven otherwise. And when I see that in my chart, that means I've told the patient that actually up to 2 years, most likely within 6 months, but up to 2 years after a trip, any fever with or without symptoms, it could be a common cold, it could be fever by itself, fever with a headache, fever with a rash. Any significant fever is malaria until proven otherwise. And I tell them, you don't wait to go to the family doctor, you don't wait to go to the walk-in clinic, you go straight to Emerge and ask them to do malaria testing. And most Emerges now, 10, 12 years ago, I would tell people to ask to do thin and thick films, but I think in most communities now, we do that, and even in Abbotsford, we have certain quick tests that we use. But the point is it's important to document that, because people think that once they've taken their malaria medicine, they're fine. And there could be the other types of malaria, such as Ovale and Vivax, that can actually occur much later. This is a really, seems like a kind of like a mathematics equation. I want to talk to you briefly about the importance of this line. Now, do you guys have access to my notes? Yes, good. So what this note says is it's Rx is your malaria prescription, plus DEET on your skin, plus permethrin on your clothes, plus a treated bed net. There are basically 4, if you can conceptualize this, you'll never go wrong when it comes to malaria. And I always think about it like this. I think of my skin, and I start with my fingertips and I go up to the sky. So I start with my skin, I start with then I go to my clothes, and then I'm in my mouth, and then I have shelter. And so those are the 4 things. It's only 4 things you need to talk to people about with regards to insect-borne illness and personal protective measures. There were 2 studies done, one in the Lancet and one by the US Army, about 10, 15 years ago, to show the effectiveness of DEET on your skin and permethrin on your clothes. I'm going to give you basically the abstract of that study right now. What happened is they had subjects that they would go into a room and they would stand there for hours. And for each hour, they would determine how many bites that they would get from malaria, or from mosquitoes. They would actually go into this room filled with mosquitoes, thousands, millions of them. And I hope they paid their subjects well. But the thing that you need to understand is that these people with just a t-shirt and shorts had 12 to 1,400 bites per hour, unprotected. They went back the next day, I guess, and then they put DEET, insect repellent, and you don't need anything more than 30%. Up until recently, Canada, you could get 99% DEET. The problem with 99% DEET was that it would actually cause a couple things. It prevents you from sweating, so it can cause you to overheat and get heat and sunstroke very easily in areas where it's hot and humid. So that kind of defeats the purpose of that one. And then the other thing is that it leaches things, it like melts things. It can just take plastics and do weird things to them, and it's kind of creepy. But 20 to 30% DEET doesn't do that to any significant degree. And it's just as effective as 99% DEET. The only difference is that 99% DEET takes a little longer to decay, so it lasts longer, up to 12 hours. Whereas 20 to 30% DEET is about basically a QID application. What I tell people is to apply it after each meal and at bedtime. And the reason after meals is because you don't want to have DEET on your hands before you eat. And so you just put on your sunblock before the meal, and then you put the DEET on after, and there's enough time for the sunblock to absorb. Sunblock's SPF is reduced by 1/3 when you put DEET on. Just another little tip. But most sunblock is 40, 50, 60% now, so that's not as big a deal. So if you're back in that room the next day with just t-shirt and shorts, and now you put DEET on your exposed areas. Mosquitoes tend to like the wrists, ankles, and neck. So you put your insect repellent, 20 to 30% DEET, doesn't matter what brand, on your legs, arms, and neck. 40 bites an hour. So you've gone from 1,200 down to 40. So there's another chemical called permethrin, and you can get Insectagon at the Rona Revi store. I know that they sell this product. I don't know anywhere else that sells it, but you can either get it there or in the US. But Insectagon is a 0.25% permethrin spray that you use for your garden, and I'll also use it as an insecticide for your home. But what you do is it's a water-based one. That's why I like about this product, because it has very few other ingredients. And so what you do is you spray your clothes about 2 or 3 days before you leave your trip, and it's good for 3 weeks and 3 washes. But if you just did that to your t-shirt and shorts in that room filled with mosquitoes, it's down to 20 bites an hour. So you've gone from, so it's better than DEET, because remember DEET was 40 bites an hour in this study. So the interesting thing is the synergy of the two. If you put DEET on your skin and wear clothing that's treated with permethrin, you will actually be 0 to less than to equal 1 bite per hour. So if we were in a cloud of mosquitoes, all of us here, we'd be in an hour during this talk, close to 100,000 bites if we were wearing t-shirt and shorts, doing nothing. However, if we had the same talk, and I could barely see the people in the back because of that cloud of mosquitoes, permethrin is kind of like Pigpen and Charlie Brown. The mosquitoes can see that, but you can't. And the thing is when you have DEET on your skin and permethrin on your clothes, it's less than or equal 1 bite per hour, so maybe 1 or 2 of us might get 1 or 2 bites total in that same room. And the reason that's important is because I can tell you for a fact, and I gotta knock wood on this, I have yet to see a patient in my practice in 20 years get malaria if they followed all those 4 things. You need to take your malaria medicine, but you need to reduce the number of bites in order for the malaria medicine to work. And it's a really important thing to understand, because if you just tell them, here's your malaria pills, you will undoubtedly get treatment failures on that. And you need to basically tell them, put DEET on after each meal and at bedtime, treat your clothes once before you leave Canada with permethrin. And if you want that handout, feel free to bug my receptionist, and I'll send you the exact same handout I give my patients on permethrin, on how to use it, how to apply it, where to get it, the barcode, everything. And the other thing is the use of a treated bed net and or air-conditioned room. So you do those 4 things, the chances of someone getting malaria is very, very low. The 3 R's of travel vaccines. Routine, basically your tetanus, diphtheria pertussis. Influenza vaccine is a routine vaccine. Hep B is a routine vaccine. Anything that's non-destination specific, that everywhere in the world you should have protection for, you should have your routine shots up to date. It's a wonderful opportunity in family practice to make sure that they're adult. Usually, in most jurisdictions now, public health looks after pediatric vaccine. So the thing with regards to adult routine vaccine is it's a wonderful opportunity to provide people with updates to their vaccinations. Give you a couple little tidbits here. Anyone born, you don't need to give Twinrix to someone who was born after 1982 if they were offered Hep B vaccine in grade 6. Now it's offered in infancy, since those people that were born in 2001 and later. But anyone born from 1982 to now has basically been offered Hep B vaccine. Anyone below that, anyone older the age of 30 right now has not usually been offered it in school, okay? So anyone in this room, basically, most of us, weren't offered it in school. Recommended vaccines, those are destination, this is the way I conceptualize it. Recommended ones are the ones that are destination specific. They're not itinerary specific. So what does everyone need for India? What's the answer? Hep A and typhoid. Those are the 2 most important, because remember, Hep B is in the routine section. And Health Canada wants every adult in Canada to have Hep B. So there are really only 2 recommended vaccines for India from an injectable point of view, or oral if you're thinking about oral typhoid, is Hep A and typhoid. There are no requirements for this family. There are only 2 required vaccines on the planet for travel at this point in time: yellow fever and meningitis. And that's if you're going to Saudi Arabia to, if you're Muslim and you're going to the Hajj, for example, the Saudi Arabian government will not allow you into the country without a certificate of vaccination against meningitis. And that is a quadrivalent conjugate that you need. Oop, backwards. So, key concept number 4, the enterics. This is what we all should be thinking about when we're dealing with travel medicine. This is 90% of it. 85%, 90% of travel medicine is dealing with the enterics and making sure that they're identified as to whether or not they're in or out of a risk for malaria. Hep A, typhoid fever, and traveler's diarrhea. Yes, sir?
Before we leave the section on vaccination, just have a quick question. A lot of times when I look at the CDC website, it mentions Japanese encephalitis.
Yes.
Only brings certain specific situations.
And you're my plant. Thank you very much. Because I didn't talk about suggested. I went right from required to the next slide, and you're quite right. The suggested vaccines would be tick-borne encephalitis if you're hiking in the spring, summer, or early fall in Europe or Eastern Europe. A suggested vaccine would be Japanese encephalitis if you're spending significant time in rural areas and in Southeast Asia. This family is basically going to areas where they're more urban, and their style of travel is such that it's actually about 1 in 3 million chance per month of travel of getting Japanese encephalitis. It's very low, but the effects can be quite devastating. This is a mosquito-borne illness. If you are going backpacking in a rural area of Southeast Asia for a considerable length of time, usually 3 weeks or more, and it doesn't matter. I mean, it's their value. I mean, if they want to spend the money on the vaccine, it just takes one bite of a Japanese encephalitis-infected mosquito to get Japanese encephalitis. So I don't think it would be out of the question to offer it to them if they wanted it, but you have to kind of draw the line, and it really has to do with length of stay. If they're an expatriate working, even if you're in Beijing and you're working in the embassy, basically the outskirts of Beijing is a Japanese encephalitis risk. And so if you're going to be there a year or two as a post with the Canadian government, you need to have Japanese encephalitis vaccine. China as well. Rabies is another suggested vaccine. And China has the highest rate of growth of rabies cases in the world. It's not just Mexico, it's not just India anymore. It's not Thailand. China is the hotspot for rabies right now.
What about Bali?
Bali is also, we see rabies in Indonesia. And what we should be thinking about and polio is a routine vaccine, but it has travel destination specific issues. But Bali is also, if you're just going to Bali to stay if you're flying into Denpasar, and Bali is an inverted T-shape or inverted triangle shaped island. The top part, think of Bali as a snow cone. The top part of the snow cone has malaria, and the bottom doesn't have malaria. That's the first thing about Bali. And the other thing is that, yes, there is risk for rabies, but most people are tourists. They're doing on their little tours. That all I would say is you don't need malaria or rabies vaccine for your trip because it's short and you're a tourist. If you were to get bit or scratched by an animal, your trip is over. You need to go straight to Thailand to the University Hospital in Bangkok to get post-exposure care immediately. You have to get the next flight out of Bali. So, yes, I will. I'm getting there in the next slide. The one thing about Hep A is if you give them Vaxum, if you give them Vacta, if you give them Havrix, the first thing is that it doesn't matter if you give them the first dose of one brand and then give them the booster dose 6 to 12 months later, and even with the Vaxum it could be 36 months later, it's been shown now, that the brands are interchangeable with Hep A. And I can't say that as well with Hep B. The data isn't as clear, but I can tell you that Hep A is interchangeable. You don't have to give Havrix the second one if they already had if they had Havrix the first time. It's effective immediately because the incubation period, it's kind of like a race. It's kind of like what gets to the finish line first. If you give them, because it takes time for the illness itself to incubate, the actual vaccine will get to the finish line before the actual illness will. And so as a result, the Hep A vaccine is effective theoretically immediately. So you can get it on the way to the airport. So there is something that we can do for those last minute travelers. Typhoid's 2 weeks. Yes? I'm sorry? If you've had Hep A or in terms of giving Hep A to a child if a person has had clinical hepatitis A confirmed, remember that many of these people were told they had Hep A because they lived on a farm. What other things can cause jaundice in a child 30, 40 years ago? Could be even mono. It could be even, you can even still have hepatitis E. There's other types of hepatitis. So if I asked them, was it lab confirmed hepatitis? If not, then maybe we should test you and do an IgG if we have time. And if we don't have time and they're leaving the next day and the history is not clear and you don't have proof that they had Hep A, it's not going to hurt them to get it. It just might hurt their pocketbook, okay? So a booster dose of Hep A 6 to 12 months later, in the case of a Vaxum, you can even give it up to 36 months later, will give indefinite protection. What happens if someone comes to your office and they had their first Hep A dose 5 years ago? Do you have to restart? No. Here's another concept. Concept number 5. You can expand a vaccine schedule, but you can't shrink it unless it's been proven by studies. So the thing about Hep A is that there's enough immune memory and enough immunomachinery, so to speak, that you can actually give a second dose of Hep A 5, even 10 years later, as long as it was one of the ones that we have. It can't be immune globulin. It has to be an inactivated Hep A vaccine, such as Avaxim, Paxil, Vacta, or Havrix. Okay? You can combine Hep A with Hep B vaccine in terms of Twinrix. The biggest thing that I see wrong is that you get your 1 dose of Twinrix and then you send that adult off. It's the worst thing you can do. If anything, give them 1 dose in each arm. Because there's a baby dose, a pediatric dose of Hep A in a Twinrix dose, an adult Twinrix dose. And so you need a full adult equivalent of pre-travel Hep A vaccine for it to work. So 1 dose of Twinrix will not cut it. There have been studies that are unpublished that certain major travel clinics in Canada are using, where you can actually give a Twinrix shot in each arm as a last-minute traveler, followed by a month later when they're going to be back to be with you post-travel, and then 6 months later. It's off-label usage, but it is acceptable. And what's very cool about that is basically it's a 0, 1, and 6 month schedule, but you're doing 0, 0, 1, 6 months. By convention, hepatitis B requires 3 doses to equal protection. If you look at data, 2 doses might give you 86%, but it's not considered high enough because that data is not terribly good. The point of what I want to say is that I still see people getting their first dose of Hep A a month later, then they go on, or B rather, they get their dose of Hep B, they get another dose of Hep B a month after that, then they go on their trip, and then 6 months later they get another dose. That's good if you want long-term protection against Hep B, but it may not help them in case that the actual Hep B virus got to the finish line before their vaccine did. So what I would like to say is that there are only basically 3 approaches to Hep B. If you have more than 6 months before they travel, do the 0, 1, 6 months. If they're leaving less than 6 months from the time that you see them, it's 0, 7, 21 days, and a year. And if they're leaving sooner than that, but they're going to be back to see you in a month, or they can access another Hep B dose while they're traveling in a safe place, then you can give them a poke in each arm of Hep B or Twinrix to give them the Hep B protection for those that are born before 1982. And if you ask them, did you get your shots in grade 6? They'll say, yeah, I got something in grade 6. Well, that's the only thing they got at that time. So 1 dose is not enough for Twinrix. Vivaxim is an adult dose of Hep A and Typhim VI. Yes?
Sorry, the dose of 0, 7, and 21, how much give them the immunity?
The question is, how effective is the level of immunity of 0, 7, 21 for their trip? And it's considered acceptably high. Okay, I don't have it's in the low 90s. Okay, and you don't give hepatitis A vaccine to infants. You want to emphasize the importance of breastfeeding for those women. Keep breastfeeding. And you're going to do the best that you can for that child. Hep A vaccine is only available for those that are 1 year of age and over. This is the Salmonella typhim, or typhi bacteria penetrating the lining of the intestine. In Canada, we have 2 types of typhoid fever vaccine. We have oral and we have injectable. The oral vaccine is a live vaccine. The injectable is an inactivated vaccine, and right now there is a shortage of typhoid injectable vaccine. Typhorix and Typhim are not available. There was a recall of Typhim VI because of a antigen issue. There's no recall of anyone who's got the vaccine, so I think they're just being extra careful. The other thing is that you can't get Typhorix right now. Fortunately, in my office, I kind of anticipated the Typhorix thing. I have lots of it, so I'm fortunate that way. Oops. But most of us will only be able to offer people right now, in October of 2012, for a few more months at least, the only thing that you can offer them is Vivotif. And Vivotif is only available for those that are ages 5 and up. And you take a pill on alternating days. and it takes 7 days to get the medicine into their system. Up until about 5-6 years ago, we had another medicine from Crucell, and that one was called Vivotif as well, but it was a sachet of 0, 1, or 0, and then 3 days and 5 days. And the nice thing about that was that you could give it to children 2 to 5, but we don't even have that option. So we're kind of hooped right now in Canada. If you don't have access to the injectable form of typhoid, you can't break up the pill officially. So we have to maybe be creative, because you have to take it with water. Do your best. You might want to, I don't know what to tell you with regards to 2 to 5-year-olds. That's the only issue. And it gives you 7 years protection. The injectable typhoid is better for toddlers, like I said. If you've had, this is pearl number 6, if you've had 2 people, or if someone in your practice who's had 2 doses of Typhim VI or Typhorix, polysaccharide vaccines, whether it be pneumococcal, whether it be meningococcal like Menomune, not the Menactra, or Menvio, whether it be typhoid vaccine that's injectable, you get hyporesponsiveness. The best way I can tell you is that it's kind of like a NiCad battery. It's not a lithium battery in terms of your immunoresponsiveness. Every time you get another booster, it's less and less and less, to a point where it actually becomes less and less effective. So repeated uses, if you're seeing a missionary who comes home for Christmas every 2 years, and they want it, or 3 years, and they want their typhoid vaccine from you, you need to give them the oral. And the reason is because this polysaccharide hyporesponsiveness is a real thing. And that happens with any polysaccharide vaccine. Traveler's diarrhea. The one thing that will affect the quality of your trip is traveler's diarrhea. So I coined, who are the high expectation travelers? Those are people that are traveling less than 3 weeks, who can't afford to get sick. Business people, athletes, honeymooners. People who've saved up a lot of money to go on a trip that they haven't gone on for a long time. Anyone who can't afford to get sick between 5 and 7 days. And so for every 100,000 travelers, 75% of travelers per month of travel will get traveler's diarrhea. Enterotoxigenic E. coli, not the type that we're hearing in Canada now. This toxin causes the most common causes of infectious traveler's diarrhea. For example, 60% of all cases of traveler's diarrhea in Mexico is ETEC related. 85% in Ecuador. 75% in Peru. Less in Southeast Asia. About 40 to 60% in Africa. It varies. So the common question that I get is, why then should my patients be taking Dukoral if it doesn't work? Well, that does work. It reduces your risk of getting diarrhea. But what it does is it's a step in the equation. And we have 2 more minutes. And so the thing that I wanted to say is that Dukoral is an important vaccine if you don't rely on it completely. You still need to be a good defensive eater and drinker. And if you do get ETEC-related traveler's diarrhea, there is a 500% increase in the risk of irritable bowel. So most people who get irritable bowel post-traveler's diarrhea will say that the irritable bowel was worse than the diarrhea itself. And that's something that they have to remind themselves about having while they're back at home. So Dukoral does have a role. And that's this study that was shown about the risk for irritable bowel. Boil it, cook it, peel it, or forget it. Easy to remember, hard to do. Eater's remorse trick. The reason Australians often don't get traveler's diarrhea is they drink heavily. We use hand sanitizer on our hands to kill germs. Well, you can do the same thing with hard alcohol, not liqueurs. But if you actually, and this is true, this will work. I'm not telling your patients to get sloshed, okay? I'm not telling them to drink and drive, but if they had ingested seawater near a resort where the effluent goes out and a big wave hit them, well, tell them to go straight to the poolside bar and have a shot of whiskey or a shot of tequila, because that alcohol will kill germs on contact just like it does on your hands. It's really no different. So the eater's remorse trick. If you had eater's remorse, the same thing. A little tequila will prevent you going to the, whatever. You can create your own little saying. Fluorostor, not bad. Pepto-Bismol, okay. Antibiotics for prevention, a no-go. And vaccine, Dukoral, traveler's diarrhea, that's what it looks like. That's the percentages that I said, and now I'm flying like I shouldn't be because I really enjoy talking with you guys. The point here is that the ETEC component for Dukoral lasts 3 months, cholera 2 years, and booster doses, you just need 1 dose. And basically, the rest is on your handout. All I can tell you here for Dukoral, it not only protects against ETEC, but mixed enteric infections, including salmonella. And yes, the cost of traveler's diarrhea episode in the high expectation traveler is quite enormous, so it may be worth the diarrhea, or the Dukoral, may not be worth the diarrhea. This explains it, another way of explaining it. Remember, the Dukoral is a step in the equation. I use a seatbelt. Remember, when we get into our car, we actually wear a seatbelt, and that reminds us that we can die. But we're not going to die from traveler's diarrhea usually. The thing is that with traveler's diarrhea, you still need to be a good defensive eater and drinker, even if you take the Dukoral. You just can't rely on it, okay? And then the treatment, which is basically, you know what to do. And Cipro, this is the last thing I'm going to say. Ciprofloxacin we are not using it in India as much now, and we don't use it in Southeast Asia. We basically use Zithromax. And Cipro still works in other places, but you can still get in a recent Canadian Medical Association journal talked about Cipro and fluoroquinolone and liver toxicity. You saw that, some of you. And also Cipro in the dehydrated traveler's diarrhea patient may be harder than kidneys. So Zithromax, 4 pills all at once as a single 1 gram dose might be the best thing for you, and maybe 500 milligrams for your adolescent patient. And that's all I want to tell you.
So thank you very much, Dr. Cherniwchan.